We representing the Euromedia Publishing Group that was created with the cooperation of Research Institute of Urology in Moscow. So our main goal is provide the state-of-the-art scientific information from the international congresses and scientific meetings from all over the world to Russian urologists, because it's very difficult to Russian doctors came to attend the different conference because of a long distance. So in Russia you are well known as a prominent specialist in the andrological field. So according to this, I want to ask you some questions about different andrological issues. So first of all, it's a very big problem in andrology is nocturnal intermittent priapism. So how do you think, what are the causes and the best treatment for this disease?
Okay. Priapism, nocturnal priapism is a very important disease, with very large numbers in andrological fields. And we think today that the most important cause of the nocturnal priapism can be the neurogenic damage. Mm-hmm. With the neurogenic damage, we have lesions in the anterior hypothalamus, mm-hmm. and then this type of damage can cause very long nocturnal erection, because it's totally changed the organization of the REM sleep nightly, and then this phase of the sleep can be totally changed. Then it's necessary to identify this type of disease. We have the RIG scan, the nocturnal RIG scan, to monitor this type of direction. And the real thing that is not easy is the treatment of the priapism. Then we have very used therapies in the past, has, for example, the beta blockers, mm-hmm. but today we prefer to use antidepressive, anti-serotoninergic drugs dedicated to the check of REM phase in the sleep, and mm-hmm. especially with this type of antidepressant therapies, it's possible to obtain good results. The problem is to stabilize this type of chronic disease, and the last results has to be increasing, I think, for the future. But this is the right way where it's necessary to work and to obtain more high-level, scientifically talking results.
Mm-hmm. Okay, thank you. The next step, either now or in the future, our therapeutic targets, excluding PDE5 inhibitors, for treating ED, because several years we have no new type of drugs for treat this disease. What do you think about this? Should we await something new in this field?
In the large field of the ED therapies, after 15 years becoming from Viagra to Cialis, and waiting the new drugs as Avanafil or Udenafil for mm-hmm. This year, with Avanafil with Udenafil in 2014, there is a space for other drugs. First of all, I would talk about the Bayer 60 we have used in our department as chairman of this in Italy, as this trial is a totally different way, totally different from the NO pathway. Is a guanylyl cyclase mechanism, is another pathway totally different from the NO system, but unfortunately the last results are absolutely not satisfying, because in the group where we used with other researchers BA60, we obtained the same results that we obtained with the vardenafil alone, and in the combination vardenafil plus BA60, the results are absolutely not different from the vardenafil alone. Then we, at this moment, we have absolutely abandoned this type of trials. Then we have the very important therapies has inhibitors of Rho kinase is another pathway at the same, totally different from the NO system, and the inhibitors of Rho kinase can have very important results in the therapy of ED. Especially the molecule, the name is fasudil, is very important for the future of the utilization of the Rho kinase system. Last but not least, we have a very special experience in our department obtained with the urotensin 2. This is another very important pathway that we use as vasodilators in the erectile dysfunction, and the result is very, very good. Then I think in the next future, in the next 2-3 years, we can have other very important drugs that we can use in erectile dysfunction. I am sure that we can have excellent drugs in the next future.
And how long should we wait before these classes of drugs will be introduced? What do you think? How many years should we wait before introducing these drugs in the clinical practice?
A realistic timing of waiting, it can be 2-3 years, no more.
2-3 years?
Yeah.
Oh, great.
I hope.
And in Russia, there is very widespread using of herbal medicines for treating ED. The many different drugs, many different substances using for this. What do you think about using of herbal medicine in treating ED?
I totally disagree. Why? Because there isn't absolutely no evidence-based medicine that clarify that the herbs in erectile dysfunction can be the right way. Medicine is a science, so and so precise, and then I think it's difficult to understand why a patient with herbs can have an increasing of the results in his erectile dysfunction. I think we haven't absolutely no PubMed, and then if in medicine we haven't PubMed, a good physician doesn't use this type of solutions. Then this is the first thing. The second thing is that with PD5 inhibitors we obtain immediately results, and then this type of patient is a delicate patient, and then it's necessary to give him immediately strong and very convincing results. And with the herbs, I think it's very difficult to obtain this type of mean average of results. Then I think the problem is to avoid these empiric therapies and to go directly to very efficacious therapies.
Okay. The next huge problem and hot topic for discussion among Russian urologists is treatment of varicocele in adolescents. So, whether to operate as a preventive measure?
We know that pathology, varicocele in adolescence is prominent because in comparison with the usual medical literature, we know that the knowledge of the relationship between varicocele and infertility is estimated about 15%. In my personal experience, this percentage is higher, is about 20-25%. Then we are very clear in our mind that it's necessary to intercept this type of pathology when we have the clarification that this is a varicocele or monolateral or bilateral varicocele. In this type of perspective, it is necessary to stop the damage of varicocele on the testis, and then it's necessary to operate. Then I think it's very important to give this message to the audience that and the families, if there is a varicocele, it's necessary to operate this type of very young patients to protect the gonades from the thermical, because it is a thermic damage, and then it's necessary to stop this damage with the operation. And this is the right way to protect the fertility. It's necessary to give this type of message to pediatric specialists, because in the pediatric specialty it's very difficult to understand that this type of operation is fundamental for the future husband, and then it's necessary to protect this type of situation.
So totally you think that it should be done, this operation as a prophylactic?
This is a cultural problem. A cultural problem for the families, especially for the mothers, and for the pediatrics too.
Oh. Okay, and one more interesting question. The very popular meaning mentioned in Russia that the chronic prostatitis has a very strong link with erectile dysfunction. Can you explain us, is there a link or not between chronic prostatitis and erectile dysfunction?
The answer is absolutely no. Why? Because the erectile dysfunction is a neurohormonal vascular disease, and prostatitis is phlogistic disease. And there is no relationship between them. First. Second point, we can have only a psychological relationship between erectile dysfunction and prostatitis, because when the man has an intercourse, it's possible to have pain linked with the erection, but not dependent by the erection. Then the pain can stop the erection for the ejaculation problem, not for the vascular problem linked with the erection. Then we have these two different pages of andrology. In one there is the erectile dysfunction, in the other is prostatitis and ejaculatory disorders. This is absolutely independent page. The only thing that can link these two different pages can be the disease of the ejaculation when we have the erection, but absolutely is necessary to clarify there is no relation between them.
Because many doctors are trying to explain this link because of the cavernous nerves goes near the prostate, and when the prostate involved in the inflammation, these nerves are damaged.
I don't think this scientific issue. I never read before.
One more issue near the prostatitis, near the prostate.
The problem is to treat the pain.
Yes.
We have,
how to pain the chronic pain.
We have very important drugs involved in this type of therapy. We have the steroids, the anti-inflammatory, we have seranoarepents, we have very important drugs, antibiotics. Quinolones is possible to treat the pain, and okay, when we solve the pain, we can have better results in the erection. Not totally true, but it's necessary that to differentiate these two moments, because if the physician or urologist or andrologist doesn't know this type of very clear physiopathological process, the physician can increase the psychological aspects, the negative aspects of the perception of the patients. And then it's necessary to stop this problem, because if the urologist doesn't stop, can increase the psychological complication of the history. And then it's necessary to clarify this is prostatitis, it's not linked with the erection. Then when we solve the prostatitis, your erection goes well.
Some articles advise us to use even the extracorporeal shockwave therapy to treat the chronic abacterial prostatitis. Maybe you have some
I'm
meaning about
very
this?
linked to this page because as chairman of the European section of andrological urology, one of my most important field of interest, scientific interest, was and will be the shock waves. My center, I think, is one of the most important center in Europe, and I think myself and Professor Weidner in Germany, in Gießen, are the two most important centers in Europe. We have dedicated a lot of energies, we dedicate a lot of time to electroshock waves. Electroshock waves are very important for the Peyronie's disease because we break the plaque, we create fractures inside the plaque, and then can be a neo-angiogenesis process. Then we have new vessels, and the vessels go inside the plaque, and then we have new vascularization of the sclerotic tissue. It's very important. In my opinion, it's the first line of therapy in Peyronie's disease. The future for electroshock waves can be the pain in prostatitis, because when we treat the perineum, where we have the prostate, the electroshock waves create a neovascularization, and this hypervascularization can solve the pain with the vasodilatation. When we use the electroshock waves in erectile dysfunction, we can obtain excellent results because we create a direct activity on the endothelial cells, and on the endothelial cells we can have an increasing of the positive metabolism of the cells, and then we can have a real restoration of the erection. Then we have a very important point in Peyronie's treated by shock waves in erection, in erectile dysfunction, and absolutely in pain in prostatitis. Then I think electroshock waves can be a very important step in the future.
Oh, great. So the next disease, the next condition is infertility. So according to the EAU guidelines, the idiopathic infertility occurs in 30% of cases. So you don't feel it's too much? Because when we say idiopathic, so we say we don't know the reason. And I don't know another condition where its idiopathic cause would be so much. Maybe we don't know some steps of pathogenesis of infertility, or maybe we haven't appropriate tools for diagnosis. What is the reason of this? What do you think?
The reason is very clear. After a long history when the woman was the only responsible of the couple infertility, only lies, I think, in the last 30 years, urology has focused the attention of the male infertility. Today we know well that the 50% of infertility, of couples infertility, is linked with the male responsibility. The problem is to identify after the pediatric age this type of causes, and then we have first of all the varicocele. We have already talked about this point. We have cryptorchidism, hydrocele, hormonal pathologies, but we have today about, I totally agree with this type of percentage, because in my personal experience the 30% of patients has idiopathic pathologies. It's not easy today to understand well all this type of process. I think the future in this field can be the molecular biology, and then I hope with the very important increasing process that we obtain with the molecular biology, we can have more and more precise results in this very large part of idiopathic infertility. Fortunately, now we have all the assisted procreation therapies, and then we can solve this type of problem in the couples. But I think it's necessary to go with more studies, more PubMed, very consistent scientific evaluation this type of patients. I think it's necessary to work very, very strongly in this field.
Okay, I understand. So when we are finished with the clinical issues, I want to ask you some organizing and scientific maybe questions. So first of all, andrology, as we know, is a separate specialty in Italy. So how it became a separate specialty, when it was, who started this process, maybe you know?
It's not precise question, because why? I'm sorry, but it's difficult to understand what is in Italy the situation, but is in all over Europe. First of all, andrology in Italy, for example, and was I think with Germany, I think the oldest society, born in 1976 in Pisa, in Italy. And this type of societary construction born between urologists and endocrinologists. Then this long process, about 50 years, it was very, very long. It has been very, very long. And when after 30, 40 years, the andrology, and I was in the beginning of 2000 president of Italian Society of Andrology, and then I tried to obtain the independence from the urology and from the endocrinology. We taken considerably the opposition of the urology and endocrinology, because andrology is very, very important field and very important part, about 25% of urology, and I think it's the same for endocrinology. And then it's not easy it's like the old Yugoslavia or the Soviet Union, when this type of country lost a very important part of its territories, and it's not easy to accept this type of situation, naturally. Then we took this very important resistance from urologists and endocrinology, and then the final results was negative. And then today we haven't a postgraduate school dedicated to andrology. Then when we talk about andrology, we talk about urologists with a very important interest in andrology, and we talk about endocrinologists with very important interest in andrology. But today, sorry, we haven't this type of independence of this very important field. Then when I became chairman of the European section of andrological urology, immediately the first desire was to realize in Europe that was impossible to realize in Italy. But we have taken the same resistance, because we have a very important society as this European Association of Urology, and there is another very important European Academy of Andrology supported by endocrinologists, and then we have intercepted the same resistance that we intercepted in Italy. Then, at this moment, concretely, we have in our hands only one thing. We can have a master where we realized after the 2 postgraduate school of urology and of endocrinology, and then 6 years of medicine, 5 years of urology, and then 2 years were responsible to have a master in andrology. But at this moment, we haven't in Europe a real specialist in andrology. The only thing that we have is this master, combined between a section of andrological urology of EAU and with the European Academy of Andrology by the endocrinologist. Then when we talk about andrology, there are urologists and endocrinologists, but not pure andrologists. But andrology is very important for both, I think. And then for young urologists and for young endocrinologists, I think andrology is a fundamental part of the didactic corpus of the formation in our postgraduate schools.
So most of the centers are state, federal, or municipal, or local. What is the structure? So the most andrological centers, urology. So is it the state clinics?
The major part is state clinic, then there is the recognition of the Ministry of Health or the university department, but the same way in andrology we have very important private centers because andrology is, has a large diffusion, and the number of patients is very, very high. Then we have very, very consistent private centers in Italy, but in all over Europe. And then the quality level of this type of center is absolutely high. We have these andrologists, urandrologists in, for example, here in our European Congress, and then the level is absolutely good, and then the quality of the therapies is absolutely clear and absolutely of high level, then there is no problem.
The Italian Society of Andrology control these private practicing specialists or not?
In Italian Society of Andrology, we have about the 25% as members of Italian Society of Andrology from the private, and then these members are absolutely under the control of Italian Society of Andrology. They respect the guidelines, they respect the EBM, and then this is no difference between private and public offering. Then I think is necessary that we can understand the private is absolutely in the same line of the public centers.
How the Italian Society of Andrology is involved in lawmaking? Do you create some maybe obligate standards for treatment, some guidelines that will be obligate for using, or maybe you are take a part in the making of federal law in the healthcare fields or educational fields? So as a public organization, I mean.
Yeah, andrology is very important because today the quality of life of the patient is fundamental, and then the same Ministry of Health in different national countries give more importance to the quality of life, and then it's important to have a relationship between the andrological societies with all the public organizations. Then I think it is very important because there is a big difference between women and men, because for the women in Europe there is a very more attention to all the problem linked with the women, for example breast cancer or cervical cancer, or all the prevention, incontinence too. And then for the men there is not the same interest, and then I think if the uroandrological attention raise up, we can have obtain more interest from the public organization. Then it's necessary to increase the level of attention of the patients, the male patients, on the sense of the awareness, the sense of the prevention, the sense of understand that all the disease today can be treated. This is not easy because when a woman spend 2 weeks to go to a physician for the same problem, a man spend 2 years. Then there is a very large space of interest in comparison between men and women, and then this type of very unbalanced process has to be correct.
Okay, so thank you very much indeed for these great answers. I think our Russian urologist will be it was very important for us, for our doctors, because the level of information and quality of information that we can deliver to Russian doctors is absolutely important for us. So thank you very much.
Thank you. Okay.